Hello, everyone. My name is Saurabh Chandan, and I'm an assistant professor of gastroenterology at Creighton University School of Medicine in Omaha, Nebraska. On behalf of my co-authors, I'd like to thank Gastrointestinal Endoscopy Journal and the ASGE for giving me the opportunity to discuss the findings of our recently published article, Risk of Post-Sphincterotomy Bleeding with Antiplatelet and Anticoagulant Use, a propensity-matched analysis of United States Collaborative Network. Gastrointestinal bleeding following endoscopic retrograde cholangiopancreatography, or ERCP, is a serious adverse event and most commonly occurs after endoscopic biliary and/or pancreatic sphincterotomy. The reported rate of post-sphincterotomy bleeding is estimated to be 0.3 to 2%, but varies according to the definition of bleeding. Per the American Society of Gastrointestinal Endoscopy, while the strength of available evidence for post-sphincterotomy bleeding risk is high for therapeutic warfarin and heparin, it remains unknown for antiplatelet agents such as clopidogrel and prasugrel. Additionally, in certain clinical scenarios, such as severe ascending cholangitis, urgent biliary decompression with ERCP may be warranted. Furthermore, in patients on chronic anticoagulation or antiplatelet therapy, timely drug cessation may not be possible. Given the limited evidence regarding the safety of ERCP with sphincterotomy in patients on antiplatelet and antithrombotic agents, we conducted a retrospective United States-based propensity-matched cohort study utilizing a multi-institutional research database to assess the risk of post-sphincterotomy bleeding in patients on anticoagulant and antiplatelet therapy and compared our outcomes to a matched set of controls. A real-time search and retrospective analysis of the US collaborative network in the Trinatex platform was conducted and updated through December 2022. Patients who underwent ERCP with a sphincterotomy were identified using current procedural terminology or CPT codes. Additionally, only patients who had ERCP within 7 days of hospitalization were included in the study. The primary aim of our analysis was to evaluate the risk of GI bleeding in the anticoagulation or AC cohort, including among those patients on heparin bridging therapy, as well as antiplatelet or APT cohort compared to controls. One-to-one propensity score matching was performed for age, BMI greater than or equal to 30, gender, race, ethnicity, history of diabetes, nicotine dependence, presence and severity of chronic kidney disease, cirrhosis, as well as thrombocytopenia between the cohorts. Our analysis identified 1,806 patients in the AC cohort that underwent an ERCP with sphincterotomy. 63% patients had choledocholitis, 36% had cholangitis, 14% had pancreaticobiliary malignancy, and 2.2% patients had a bile leak. After propensity score matching, patients in the AC cohort were found to be at an increased risk for GI bleeding compared to the control cohort with an adjusted odds ratio of 3.6. Subgroup analysis was performed in the AC cohort based on the concurrent aspirin use. After propensity score matching, patients in the AC cohort on aspirin were found to be at an increased risk of GI bleeding compared to AC cohort patients without use of aspirin, with an adjusted odds ratio of 2.0. We created a separate control cohort to assess the risk of GI bleeding in patients on AC who were on heparin bridging therapy within 48 hours prior to undergoing an ERCP with sphincterotomy. After propensity score matching, we found no difference in the risk of GI bleeding between the AC cohort and controls on heparin bridging therapy. Furthermore, patients in the entire AC cohort who developed GI bleeding were not at an increased risk for need for blood transfusion, ICU care, or all-cause mortality compared to matched controls. In the APT cohort, we identified 1,000 patients that underwent ERCP with sphincterotomy. In this cohort, 62.3% patients had choledocholitis, 39% patients had ascending cholangitis, 13.9% patients had pancreaticobiliary malignancy, and 1.6% patients had a bile leak. After propensity score matching, patients in the APT cohort were found to be at an increased risk for GI bleeding compared to controls with an adjusted odds ratio of 2.2. Subgroup analysis was performed in the APT cohort based on concurrent aspirin use. After propensity score matching, we found no difference in the risk of GI bleeding in the APT cohort on aspirin compared to those without aspirin use. Additionally, patients who developed GI bleeding were not at an increased risk for the need for blood transfusion, ICU care, or all-cause mortality. We also found that patients who received anticoagulation within 24 hours of the procedure were at a higher risk of GI bleeding compared to patients who did not. In the APT cohort, however, no such difference was observed. In conclusion, our analysis shows that patients on antiplatelet therapy, warfarin, as well as direct oral anticoagulants have a significantly higher risk of post-sphincterotomy bleeding following an ERCP. Concurrent use of aspirin with anticoagulant agents further increases this risk. Thank you.